Welcome to this case discussion on progressive dyspnea and recurrent hypercarbia. We will explore the case of a 50-year-old smoker with a complex medical history, including emphysema, sleep apnea, and repeated hospital admissions for hypercarbic respiratory failure requiring BiPAP. This patient's story challenges a simple lung-only explanation. Throughout our discussion, we will use each stage of the case to assess whether advanced smoking-related lung disease is sufficient to explain the presentation or if the ventilatory pump itself is failing. The specific diagnosis will be revealed only when the evidence fully supports it. Let's begin by outlining our learning objectives for this session. Our learning objectives for this session focus on defining our clinical reasoning and practical priorities. From a clinical reasoning standpoint, we aim to understand why current hypercapnia, orthopnea, and morning headaches might signal ventilatory pump failure. We'll also practice revising our working diagnosis when the clinical pattern extends beyond a simple COPD-OSA overlap and track how new data blocks influence our localization and confidence. Regarding practical priorities, we will emphasize sequencing bedside physiology ahead of premature disease labels. We'll learn to interpret a combination of mixed obstruction and restriction, low MIP-MEP values, and phrenic study results in a comprehensive way. Finally, we will translate our confirmed diagnosis into immediate respiratory and long-term management strategies. Next, let's review the format of our session. This session is structured to facilitate a dynamic and interactive case discussion. As shown on the left, the how each stage runs section outlines our process. The doctor will reveal new case data, followed by an audience pause for reflection. Then a resident LLM will offer an initial diagnosis, differential, and next steps. A consultant LLM will critique the reasoning, sequencing, and safety aspects. And finally, an expert LLM will synthesize the best fit at that moment. For the audience, our ground rules on the right emphasize staying within the provided script and avoiding premature conclusions based solely on visible emphysema. We encourage everyone to constantly question whether the lungs alone explain everything or if the respiratory muscles are telling a different story. With these guidelines in mind, let's dive into the initial presentation of our patient. Let's begin with the initial presentation. As you can see on the left, certain historical elements tend to anchor the team to a lung-focused diagnosis. We have a 50-year-old man with emphysema, obstructive sleep apnea, multiple neuropsychiatric diagnoses, and a significant 35-pack-year smoking history. He's had 3 admissions in the past year for acute hypercarbic respiratory failure requiring BiPAP. Even after changing CPAP to BiPAP and stopping sedating antipsychotics, his symptoms persisted. However, as noted on the right, under clues that should unsettle that anchor, each admission started with drowsiness and falls, described as his legs giving out. He also reported exertional dyspnea, morning headaches, daytime sleepiness, mental fogginess, and neck-hip pain. Crucially, he denied common pulmonary symptoms like cough, wheeze, fever, or chest pain, and also lacked weight loss, sensory, bowel, or urinary complaints. Now, let's pause and consider what these initial clues might signify. At this audience pause, we need to critically examine the initial presentation before our diagnostic frame becomes too rigid. The core question is, what makes this more than just severe smoking-related lung disease? Consider the first bullet point. Which symptoms specifically point towards nocturnal hypoventilation or diaphragmatic weakness rather than typical COPD flares? Think about the significance of the falls, orthopnea, and the persistence of symptoms even after reducing sedatives, as highlighted in the second question. How much weight should we assign to these findings? Finally, before we jump to a specific neuromuscular diagnosis, what bedside physiological assessments would be most appropriate to obtain next? Take a moment to reflect on these points before we move on to the expert reasoning. Now, let's review the reasoning from our expert panel at stage 1. As you can see, all three voices agree on the importance of considering ventilatory pump failure early rather than immediately settling on a disease label. The resident LLM quickly moves towards chronic hypercarbic respiratory failure from neuromuscular weakness, prioritizing myasthenia gravis, myopathy, and early motor neuron disease over a simple COPD OSA overlap. They call for specific tests like upright and supine spirometry, MIP MAP, and EMG, NCS. The consultant LLM, while approving the shift away from a lung sleep anchor, cautions against prematurely naming myasthenia or ALS. They emphasize rechecking current CO2 and bicarbonate on optimal BiPAP settings and keep non-adherence and occult cardiac disease in the differential. The expert LLM defines the syndrome as chronic alveolar hypoventilation from respiratory muscle weakness pending physiological proof, explaining how the repeated hypercarbia, orthopnea, morning headaches, and limb axial clues better fit a failing ventilatory pump than a pure gas exchange problem. This collective reasoning leads us to a crucial shift in our differential diagnosis. Following the initial presentation and the expert reasoning, we see a significant differential shift. As highlighted on the left, our leading explanations after stage 1 now include neuromuscular ventilatory failure or diaphragmatic dysfunction, COPD-OSA, overlap with persistent nocturnal hypoventilation, and obesity sedative related hypoventilation or other cardiorespiratory mimics. The teaching pearl on the right underscores this pivot. Recurrent hypercapnia combined with orthopnea and morning headaches should immediately trigger an investigation into bedside respiratory muscle physiology. The fundamental question evolves from which disease is it to is the ventilatory pump failing? This marks a key pivot where, while emphysema may still coexist, it no longer fully explains the entire clinical picture. Now, let's examine the examination and physiology findings that further complicate the initial COPD story. Moving into stage 2, let's examine the new data from the examination and physiology. On the left, under examination and imaging, the patient was afebrile with a heart rate of 108 and blood pressure of 119/60 thirds mmHg. His room air saturation was 95% at rest, dropping to 93% on ambulation, with a BMI of 25.3. Physical exam revealed diffuse diminished breath sounds but no crackles, wheeze, raised JVP, edema, or murmur. Crucially, there was mild bilateral hip weakness on abduction and extension, while tone, reflexes, pistol strength, and gait remain normal. A CT scan showed severe upper lobe predominant paraseptal emphysema, apical scarring, and an elevated right hemidiaphragm. On the right, under pulmonary function profile, FEV1 was 46% predicted, FEC 54% predicted, and FEV1/FEC was 66%, confirming real obstructive physiology. However, PLC was only 51% predicted, indicating an added restrictive component. MID was 49% predicted, and MEP 46% predicted, strongly suggesting respiratory muscle weakness. The echocardiogram was normal, and he could not complete single breath diffusing capacity testing. Now let's pause to interpret these new findings. At this audience pause, the physiological data presents arguments from both sides, making the interpretation more complex. Our central question is, how do you interpret obstruction plus restriction in this smoker? Consider the first prompt. Which single finding most significantly weakens the idea that emphysema alone can explain the recurrent hypercarbia? Next, reflect on the low MIP MEP values and the elevated hemidiaphragm. Do these findings move you from simply recognizing a syndrome to more precise localization of the problem? Finally, what should be the immediate next step? More lung workup, specific diaphragm testing, or a broader neuromuscular evaluation? Think through these questions as we prepare to hear the expert reasoning for stage 2. In stage 2, the reasoning clearly starts to favor a weak pump plus bad lungs scenario. The resident LLM quickly names bilateral diaphragmatic weakness from an underlying myopathy as the leading diagnosis. They leverage the mild proximal hip weakness, low MIP restriction, and elevated hemidiaphragm to prioritize neuromuscular disease over COPD, suggesting tests like CK, aldolase, diaphragm ultrasound, and EMG NCS. The consultant LLM agrees that the physiology is a major pivot but critiques the jump to an inflammatory myopathy. They emphasize rechecking current CO2 on present support and keep diaphragmatic dysfunction, cervical phrenic processes, and coexisting lung disease in consideration. The expert LLM reframes the syndrome as neuromuscular ventilatory failure alongside concomitant COPD, explaining that severe emphysema alone cannot account for the low total lung capacity and reduced respiratory pressures. This means the case is no longer just COPD with incidental weakness. It's a critical combination of a weak ventilatory pump and diseased lungs. Let's further explore why COPD alone is no longer sufficient. This slide visually explains why COPD alone no longer fits the patient's presentation, comparing key features against a lung only explanation. As you can see under feature, orthopnea and headaches are listed. The case finding shows persistent orthopnea, morning headaches, daytime sleepiness, and mental fogginess, which are better explained by nocturnal hypoventilation than by stable emphysema alone. For restriction, the TLC was 51% predicted despite clear obstructive indices. This suggests added pump failure or neuromuscular limitation. Regarding respiratory pressures, MIP was 49% and MEP 46% predicted, indicating that weak inspiratory and expiratory muscles are not expected from emphysema alone. Lastly, the hemidiaphragm was elevated on imaging, which supports diaphragmatic dysfunction and justifies focused neuromuscular testing. These discrepancies compel us to look beyond a singular diagnosis. As we conclude stage 2, it's crucial to review these teaching points to avoid common interpretive errors when mixed physiology emerges. On the left, under cognitive traps, we see how visible emphysema can anchor the entire team, and how normal gait and preserved distal strength can falsely reassure against neuromuscular disease. It's also easy to overclassify a smoker with dyspnea as just another COPD patient. To counter these traps, the better next moves on the right include confirming the patient's current ventilation status and escalating from spirometry to more specific diaphragm and nerve muscle localization tests. We must also keep structural and malignant causes in mind while defining the syndrome. The overarching teaching pearl here is that low total lung capacity plus low MIP, MEP in an obstructed patient should strongly prompt a search for a failing ventilatory pump. This brings us to the next stage, where we delve into laboratory and neurophysiology findings. Now, in stage 3, we reveal the laboratory and neurophysiology results. As indicated by the doctor's input, we are looking at muscle leak, diaphragm weakness, and absent phrenic responses. On the left, under blood gases and exclusion workup, the clinic arterial blood gas on room air showed a pH of 7.42, PaCO2 of 47 mmHg, and PaCO2 of 93 mmHg. During an earlier admission, the pH was 708 with a PaCO2 of 113 mmHg, confirming severe acute on chronic hypercarbia. Blood counts, electrolytes, CRP, IgE, alpha-1, antitrypsin, autoimmune testing, and myasthenia antibodies were all normal or not supportive of other conditions.
Moving to the right, under muscle and diaphragm clues, AST and ALT were mildly elevated with normal GGT and albumin.
CK was 891 U/L, and aldolase was 18.1 U/L, both elevated. Fluoroscopy showed an elevated right hemidiaphragm with decreased movement of both hemidiaphragms and no paradoxical motion. Crucially, phrenic nerve responses were absent bilaterally, and EMG showed chronic C5-DC6-C6 neurogenic changes without active denervation. A cervical MRI revealed only mild spondylosis. Let's pause to consider what these findings mean for localization and diagnosis. At this audience pause, the localization of the problem has become much sharper, but the specific disease label is still being refined. The central question now is which diagnosis best unifies the proximal weakness and diaphragmatic failure observed? Consider the first prompt. Do the CK aldolase elevation and bilateral phrenic silence point more towards a myopathy, neuropathy, or motor neuron disease? Next, reflect on the absence of paradoxical diaphragmatic motion. How much weight should be given to this finding? Finally, before we declare a rare metabolic diagnosis, what crucial checks or investigations must still be completed? Think through these questions as we prepare to review the expert reasoning for stage 3. In stage 3, the possibility of POM disease rises, yet the consultant maintains a cautious approach. The resident LLM now identifies late onset POM disease as the leading diagnosis. This is supported by the combination of proximal hip weakness, elevated muscle enzymes, diaphragmatic failure, and absent phrenic responses, pointing to a metabolic myopathy. Consequently, the resident requests a dried blood spot enzyme assay, GAA genetics, and potentially a muscle biopsy. The consultant LLM, however, warns against premature diagnostic closure on Pompe, noting that chronic neurogenic EMG changes and heavy smoking still necessitate considering cervical motor neuron or apical malignant phrenic processes. They prioritize repeating an arterial blood gas on current BiPAP settings and chest imaging with contrast or PET if needed. The expert LLM accepts late onset POM as the best fit at this stage, primarily because the respiratory failure is disproportionately severe compared to the limb findings. They explain why autoimmune myositis, myasthenia, isolated phrenic disease, and COPD no longer adequately unify the complex clinical picture. This brings us to a synthesis of the investigations. Let's synthesize the investigations from stage 3, highlighting what strongly points toward late onset Pompe and what still warrants caution. On the left, why Pompe rises includes the midlife onset with mild limb girdle weakness but major diaphragmatic failure alongside CK and alveolus elevation with a mild AST, ALT leak, and normal GGT. Negative serologies for common autoimmune and neuromuscular junction causes further support this. Crucially, respiratory insufficiency disproportionate to limb findings presents a classic pattern for POMPER. However, as noted on the right, under why the consultant stays cautious, a room air clinic RCO2 of 47 mmHg does not fully quantify overnight ventilation on current BiPAP settings. Absent phrenic responses in a smoker still necessitate considering structural and malignant causes. Furthermore, the absence of paradoxical motion from fluoroscopy, while supportive, is not disease specific on its own. This leads us to a crucial teaching pearl for this stage. This stage presents a memorable teaching pearl that helps us escape the common things explain everything cognitive trap, as highlighted on the slide. When severe emphysema coexist with unexpectedly low total lung capacity, low MIP, MEP, proximal weakness, and muscle enzyme leak, it is critical to trust the mismatch. While the patient may indeed have bad lungs, the dominant danger in such a scenario is still a failing ventilatory pump. The decisive pivot in this case was not a single laboratory result, but rather the accumulation of physiological findings that the initial anchor diagnosis of emphysema simply could not absorb. This realization now leads us to the definitive confirmation of the diagnosis. Now, we reach stage 4, definitive confirmation. The doctor's input here clearly states that enzyme deficiency and pathogenic GAA variants close the diagnostic loop. On the left. Under confirmatory tests, we see that dried blood spot testing showed acid alpha glucosidase activity of 2.4 nanomole per hour per milligram of protein, which is clearly below normal. Further genetic sequencing found compound heterozygosity for two pathogenic GAA variants, C-3, 2, 13G and around 525 del. These findings provide irrefutable evidence. As a result, the meaning of the reveal on the right is that the case is now definitively diagnosed as late onset POMC disease. Smoking related emphysema remains present, but it is no longer the primary explanation for the recurrent hypercarbic decompensations. The emphasis now shifts from diagnosis to ensuring respiratory safety and initiating disease specific follow up. Let's see how the team reasons after this confirmation. Following the definitive confirmation, the team's reasoning shifts to management. Yet, bedside priorities remain in view. The resident LLM declares late onset POMC disease confirmed, expertly connecting the enzyme result, genetics, low MIP, MAP, muscle enzymes, and bilateral phrenic dysfunction into a single metabolic explanation. They immediately focus on BiPAP optimization and referral for enzyme replacement therapy. The consultant LLM, ever practical, reminds the team that confirmed genetics do not eliminate the immediate bedside threat. They advocate for repeating arterial or venous blood gases on current BiPAP settings, longitudinal tracking of diaphragm and respiratory function, smoking cessation, and coordinated pulmonology neurology follow up before the case is considered administratively closed. The expert LLM clearly states the final unifying diagnosis: genetically confirmed late onset Pompe disease causing diaphragmatic and proximal skeletal muscle weakness, with emphysema acknowledged as a comorbidity rather than the primary driver. The diagnostic arc is now complete. Let's summarize the final diagnosis and why it fits. We now have explicit closure on the diagnosis. As you can see under final diagnosis on the left, this patient has late onset POMC disease, which is causing chronic ventilatory muscle failure and recurrent acute on chronic hypercarbic respiratory failure. This diagnosis is supported by several associated features, including mild proximal hip weakness, elevated CK and aldolas, bilateral diaphragmatic weakness, absent phrenic responses, and crucially, low acid alpha glucosidase activity with pathogenic GA variants. On the right, why alternatives lose explains that while COPD and sleep apnea are real, they simply do not account for the full pump failure phenotype observed. Myasthenia and autoimmune myositis were not supported by targeted testing. Furthermore, motor neuron or isolated phrenic processes cannot explain the enzyme deficiency and genetic confirmation. This comprehensive picture guides our immediate management priorities. With the diagnosis now secure, our focus shifts to immediate management priorities. As detailed in the table, ventilatory safety remains the top priority. The action from the script is to repeat arterial or venous blood gases on current BiPAP and adjust settings if hypercapnia persists. This is critically important because, as the consultant repeatedly emphasized, CO2 control is the first bedside priority. Next, for respiratory follow up, we need to track diaphragm and respiratory muscle function longitudinally, which is essential given that ventilatory failure drove the admissions. For disease specific care, we coordinate pulmonology neurology review and referral for enzyme replacement therapy. The expert moves here only after respiratory stabilization is addressed. Finally, COPD comorbidity remains relevant. Smoking cessation is crucial because emphysema still contributes to risk. The final frame is pompless emphysema, not pomp instead of emphysema. This demonstrates how our reasoning evolved throughout the case. This slide visually summarizes how our reasoning evolved through 4 distinct stages, representing 4 shifts in diagnostic confidence. In stage 1, recurrent hypercarbia, orthopnea, headaches, and falls made COPD-OSA insufficient as a sole explanation. The diagnostic frame shifted from purely lung disease to considering possible ventilatory pump failure. Moving to stage 2, mixed obstruction plus restriction, and elevated hemidiaphragm and low MIP map values strongly suggested a weak pump plus bad lungs, sharpening our localization. By stage 3, CK, aldolase elevation, bilateral diaphragmatic weakness, and absent phrenic responses favored a systemic neuromuscular disorder, bringing POMC disease to the forefront. Finally, in stage 4, low acid alpha glucosidase activity and pathogenic GA variants definitively confirmed late onset PONC disease, replacing diagnostic uncertainty with clear management priorities. Let's condense these insights into key teaching points. Let's condense our journey into practical bedside lessons, our key teaching points. From a reasoning perspective, recurrent hypercapnia combined with orthopnea and morning headaches should always trigger a pump failure frame in our minds. We must not allow obvious emphysema to overshadow other crucial findings like low total lung capacity, low MIP, MEP, or proximal weakness. Furthermore, a role based discussion like the one we simulated helps separate broad hypothesis generation, critical evaluation, and final synthesis. Clinically, we've learned that late onset POMC disease may manifest subtly in the limbs but can profoundly impact the diaphragm. Adult metabolic myopathy can present first in a pulmonary clinic before neurological symptoms become prominent. Even with genetic confirmation, ensuring ventilatory safety remains the most immediate and practical job. This concludes our case discussion. I invite you to consider these questions to reinforce our learning. First, which early clue most strongly argued against a pure COPD-OSA explanation? Second, how do low total lung capacity and low MIP MEP alter your interpretation of obstructive spirometry? Third, what specific features in the script supported late onset Pompe over motor neuron disease or myasthenia? Fourth, why did the consultant consistently insist on repeating arterial or venous blood gases on current BiPAP even after the differential diagnosis narrowed significantly? Finally, how should the coexistence of emphysema change but not dominate the final management plan?
Thank you for your engagement.